So thank you very much for inviting me to this fascinating conference. I must say the opening was very impressive, and I particularly memorized the sentence of the patient saying, "I woke up and found myself in another organism." And that's basically what we are all going to experience when we get very old. We will find ourselves in a completely different body. So I'm talking as a doctor in geriatric medicine, and I'm also an intensivist and a cardiologist. So, of course, this is the agenda we are going to skip in or deal with in the course of thinking when regaining strength after ICU. And at that point, I would like to mention that I do not have any conflicts of interest to reveal. Well, going to hospital may be hazardous for your health. We've heard about that. And of course, vulnerability is obviously higher when we enter the doors of a hospital because of all the stresses that act on ourselves or on the patients when they go into hospitals. So at that point, we should think twice about our conventions, our routine of practice in hospital setting. So sleep deprivation, inadequate nutrition, physical deconditioning, all this is 19th century. So I think we still are very stuck in our old school setup of hospital life, and it's getting obviously to the conclusion that bad is bad and that we should go on and mobilize the patient in a hospital setting as early as possible for anybody, particularly also for the geriatric population. It's getting even worse when we look at intensive care medicine, and it has been alluded to by the previous speakers that after recovery from intensive care medicine, the survival rate is still lower in patients having survived intensive care than in the general population, and the question is why? What do these people die of? What are the basic causes of death once you have survived ICU? And this is particularly well documented for patients having survived severe sepsis, and it's about a 20% absolute increase in mortality after survival of sepsis within the next years. Also, we've heard about the other ailments that go along with survival of sepsis, like functional disability, cognitive decline, and muscle wasting. My personal answer I would like to give you at that point on why I personally think people have an increased risk of dying after having left an intensive care unit basically is the dysregulation of the autonomic nervous system. We, in our traditional thinking of organ disciplines, dissect the body into different organs, and each specialty looks at a different organ. But the autonomic nervous system interconnects all these organs, and what we experience in any patient undergoing organ failure, severe organ failure in the ICU, or moderate organ failure when you get frail, basically, is that you have a dysregulation of the autonomic nervous system, that the sympathetic and vagal tone do not longer interact the way they used to in order to connect the functioning organs to make a complete organism. And one measure that you can take in order to get a look at the autonomic nervous system is heart rate variability. And heart rate variability basically is governed by the nerve range, sympathetic tone and vagal tone, acting on the pacemaker cell of the heart. And normally, you would see a heart rate variability. I just tried to get the pointer, I'm sorry. The normal heart rate variability of an individual person undergoes undulation in the course of a day. You will have a higher heart rate variability in daytime and a lower at night. But when you look at a person in a severe septic shock condition, like in severe inflammation, this goes like a sewing machine. The heart goes without any undulation. You have a maximum reduction of heart rate variability, a very, well, let's say narrowing of heart rate variability, which is an indicator of the autonomic nervous system dysfunctioning. And we have to think that our autonomic nervous system is one of the neglected systems of the body. On the other hand, for example, vagal tone is a very strong anti-inflammatory measure. Our ICU patients also have a very high systemic inflammatory response. Inflammation basically goes along with any ICU condition, and the vagal tone, in fact, dampens inflammatory action. So we have a cholinergic anti-inflammatory reflex, and this is, of course, also impaired once vagal tone is impaired. So this is just a hypothesis I would like to bring forward at that point, thinking that the recovery of autonomic function after ICU may be impaired and may go along with an enhanced mortality, just like severe narrowing of heart rate variability is associated with a 13-fold risk of dying. So I would like to just go briefly to the PICS syndrome. You've heard about that. I'm not going to stay with that. Perhaps just want to point out that also physical changes are experienced in patients after ICU, which mean they carry scars, they carry nerve palsies, their voice is impaired. So they have a stigmata of the ICU stay that also may be iatrogenic and also go along with PICS syndrome. I'm sorry. Yeah, you've heard about the nightmares that accompany PICS syndrome. I found that a pretty interesting cartoon, a fantasy of a patient in the ICU being persecuted by murderers or something. So this is what we have to keep in mind as well. So post-ICU syndrome, you saw that picture from Dr. Wunsch just before, is much more than just physical impairment. It's also mental and cognitive impairment at that point. The thing as a geriatric doctor that is in the focus of our efforts is the weakness, the physical weakness that goes along with PICS. And this is termed the intensive care unit acquired weakness. And from a pathophysiological standpoint, also this weakness of the muscle is very much associated with inflammation, with an overwhelming catastrophic release of cytokines, as well as with hormonal dischanges. And both the transport of glucose into the cell is compromised, and at the same time, protein degradation and synthesis are altered in a way that muscle wastes very, very soon. As soon as the patient is immobilized, muscle wasting starts immediately. And this is just the way it is subtyped, the ICU AOE subtypes. You've heard about that, the critical illness polyneuropathy, the myopathy, and the combined syndrome. And this is a point that you can, of course, diagnose with histological analysis, and much easier it can be done in a functional way, like with electrophysiological testing. Sarcopenia is a different entity. It must not be mixed up with post-ICU syndrome or intensive care unit associated weakness. Sarcopenia is a much easier to identify entity, and my main message of my presentation today to you as an auditory is, in our general medical setting, we have lab values to get an impact on the information about the kidney function, the hepatic function, the cerebral function, everything, but we know very little about muscles, and we, as internal medicine doctor, hardly ever are interested in the muscular compartment of the patient. But sarcopenia turns out to be a very important clinical problem, and actually it's addressed as the new pandemia. Particularly sarcopenia in the critically ill patients is abundant in basically every patient in the ICU, and we hardly ever take notice of it. That's what I dare say at that point as a geriatric medicine doctor and a ICU doctor at the same time. So sarcopenia is defined as a low muscle mass and muscle strength at the same time, and as a decrease in physical performance. This is the definition given by the European Consensus Conference. And we can, of course, highlight sarcopenia by imaging muscles, like doing CAT scans of thigh muscles. And sarcopenia is something that we see in old people, in in geriatric population, like in the muscles of this very old woman, but will be seen very frequently also in younger individuals in the ICU setting. Oh, I'm sorry, maybe the battery is low. Okay, and sarcopenia must not be mixed up with frailty. Frailty is a syndrome that can be seen immediately. Once you are in a practical setting as a doctor and you see a patient approaching you, you will realize immediately he or she is frail. And at present, there are more than 40 different tools in order to diagnose frailty. None of them has ever entered clinical daytime routine. We've heard about the Rockwood criteria, and there's another school to identify frailty. This is the Fried criteria, and these are people with slow gait, reduced physical activity, and early exhaustion and physical weakness. So frailty is just a syndrome of geriatric medicine, while sarcopenia is what we measure with less than expected muscle mass. And now to the critical point, can we do anything against it? So what are our options to counteract sarcopenia in the first line? Maybe going on to counteracting frailty and intensive care unit acquired weakness. This, of course, should be our goal, but I have very little to offer at that point. I would like to start off with the review of the Cochrane Library, published 2 years ago, trying to get a picture of the success of exercise rehabilitation programs following intensive care unit discharge. And to make a long story short, there wasn't any effect that could be seen when you start rehabilitation programs after ICU. So in fact, we didn't see any improvement of the patient. We are too late. And yeah, we've heard about the story or the paper by Schaller. He proposed the early goal-directed mobilization in the surgical ICU, and the difference we made in this study was that goals were defined in the daily wards. So the team entered the ICU box and defined a goal for every day that should be reached on a daytime basis. And this was, in fact, a positive trial published last year, showing that when you stick to the goals that you define on a daily basis, you would cut down ICU stay by 3 days, and you would also improve functionality as measured by a modified FIM test. So this is one of those positive studies and should give rise to hope that we have to start off early with our training in order to counteract muscle wasting and sarcopenia. Anything else? This is a bit of a disappointment, yes? Conventional training programs obviously have a limited effect in order to work against sarcopenia. So I'm going to propose 3 more options that may be of interest, but are still very experimental. The first one is neuromuscular electrical stimulation. If the patient isn't able to use his muscles, why shouldn't we go on and apply electricity from outside in order to stimulate the muscles so that he or she could retain their muscular strength? And this is a study published last year. What they did, they applied electrical current on the thigh musculature, the musculus quadriceps femoris, in patients in the ICU. And the basic effect was that by this external electrical stimulation, the muscular strength was enhanced, while the muscle thickness itself was not really altered. So obviously there's a discrepancy between the morphological muscular mass that was not really altered and the muscular performance. And maybe a little hope that we could go on and do electrical stimulation in order to prevent sarcopenia in ICU patients. The next thing is nutritional support. Do we have a chance to prevent sarcopenia by adding on, like saying, amino acids, altered amino acids? And there are a few candidates on the horizon that may be applied in ICU patients, like leucine-enriched amino acids and beta-hydroxymethylbutyrate and creatine. But also this is basically a negative study, and the recommendation would be to go on and do more detailed research, go more into pathophysiology in order to find out one candidate that could be advantageous when adding on to the diet. And my last idea, what we could do, perhaps in order to prevent sarcopenia, would be to apply an antibody against a protein that provokes muscle wasting. And this is not a study from ICU. This is something that is proposed in geriatric medicine in another setting at present. This is a myostatin antibody that may prevent frailty in older individuals. So, although at that point I have to present basically negative results for physical rehabilitation programs in the ICU patients, perhaps we could go on with some strategies more in the technical way, like applying a nerve stimulation or giving some metabolic impact with an antibody or with nutritional support. Well, of course, everybody would like to live and be fit at the same time. This was a red line of argument throughout the whole session so far. This is a lady, she lives in Halle, where I was working for some years, and she now is 90 years old, and of course, she did exercise through her whole life. She is basically not frail, but still she is vulnerable, because vulnerability is a problem of aging per se, not so much a problem of frailty. What we did is try and go on and do some more sophisticated training programs like Tai Chi for the prevention of falling and prevention of frailty, because this is not just muscular strength, but also balance training and endurance training at the same time. And of course, this is very hip. People do not like to say, I have to go to the heart sports group. It's much nicer to say I go to my Tai Chi training this afternoon. So we have to be more attractive and more perhaps innovative in our strategies to prevent sarcopenia in the ICU patient, but also in the elderly patient. And my very final slide is my favorite geriatric patient surviving his doctor despite cardiovascular risk factor profile. Yeah. I would like to sum up my presentation. I tried to show you that we, of course, have identified different syndromes of muscle wasting. The PICs we've heard about before. We've heard about the muscle weakness. I tried to make clear a point that sarcopenia is something different from frailty, and that basically at present we have some effects with early goal-directed therapy in the ICU in order to get the patient out of bed as early as possible. But we probably training per se should be supplemented and should be added by some other options like nerve stimulation, maybe antibody treatment. We have to go on and do some research. So thank you very much for your attention, and have a good conference this day. Thank you.
Thank you very much for your presentation. We have time for a couple of questions. Please.
Thank you very much for your very good talk. Well, is there any option for physiotherapy? What do you think?
Well, physiotherapy conventionally is basically what we do in our regular daytime routine, like doing exercise and trying to mobilize the patient. And you know, there are different schools within physiotherapy that basically all have the same compounds, namely balance training, muscular strength at the same time. Maybe robotics will be the future of physiotherapy. We have been talking about that this morning. And we have to be, well, lateral thinking. We have to do lateral thinking in order to get out of our conventions. That's what I say. We have so many conventions in our hospital setting, in the way we treat our patients, in the way we organize a hospital stay. So we have to just get one step back and look at our setting and think, which is just convention, which is maybe not really a sensible thing to do. And I think physiotherapy finally will end up to be some combination of robotic support, maybe some lifestyle component like Tai Chi training, and maybe also some support with let's say, nutritional agents, and maybe also metabolic support like antibody treatment. This is my perspective for the future. Perhaps in 15 to 20 years, we will have let's say, a rationale for doing just more than conventional physiotherapy at that point.
Do you think that a tailored approach with more intensive approach to more fragile patient could be helpful, or have the same approach to everyone?
A very good point. This is basically touching my research interest, because we have to categorize our patients in, even the frail community is very heterogeneous, and we have to particularly focus on the immune system. Immunosenescence probably is a motor of the organ aging, and I did not deal with that in the course of this presentation, but I think pretty well we are going to categorize in the future the frail population into those that are apt to be treated with anti-inflammatory strategies, for example, in order to prevent frailty or sarcopenia, and others that need metabolic and nutritional support. So frailty is just a syndrome, it's not a disease.